Oh, sorry. Are you feeling better? Or are you feeling better?
I am.
Okay. Welcome, Zoomers. Look at you. Who's here? Let's see. John McMillan, welcome. Share. When can you come back? I miss your face. Good to see you, Chris. Ed, welcome. Good guys. Good to see you all. Oops, my phone's ringing. Oh, no, it's not ringing. Everybody put it in my ear. Oh, it's a speaker. You're showering. No, it's on Hillbar. So get out of UCLA. Get out of the Hillbar. You'll see it. Put the in the. Yes, exactly. See you soon. All right. So our speaker is going to be here. Don't give it. Okay. Welcome everybody. Good to see you all. Let's start. Oh, is this on?
Go for it. Go for it.
Okay. Oh, as you can see, with all the merch that we have, this year it's called Magic Rotary, and I intend to make magic here. I'm not going to make you disappear, Tom, but close to it. Welcome to those zooming in, Sean, Steve, Chris, Ed. Good to see y'all. Who is that? Lawrence, okay. Let me just do that. Easy. There we go. All right. The 4-week test. Tom Barron, can you stand up and read it? But more importantly, what I'd like you to do is give an example of one of the 4-week tests and how it worked for you yesterday.
4-week test are the things they say are good. It sounds like the 10 Commandments. If you think it, we'll do it.
Okay, good.
Which book of the Bible are the 10 Commandments in?
I don't know which book, but I know it's the Old Testament. That's for sure. Exodus?
No. I'm not going to call on David.
Leviticus. Yes. Is it good? Somebody mentioned it.
That's the other one. I think that's the most important one.
Everybody, no side talk, please. Let me just.
We see so much in the papers today about political candidates not speaking the truth. So we have to do some critical thinking and absorb what they're saying. A lot of it is not necessarily the truth. Maybe exaggerations or false statements. So keep that in mind during the is very well concerned.
Could be.
Bill Goodwill, that's what this club's all about. We're beneficial to all that.
That is an excellent. Go ahead.
Take action. Should be beneficial. That's my litany for today.
Thank you very much.
Because the full 10 Commandments are Exodus and checked.
Okay, by the way, I stand corrected. The full 10 Commandments are in the book of Exodus. That's what Gordon said, and Sam is shaking. By the way, Sam is shaking his head.
Exodus 20:17.
Okay, thank you. Good. How about that, everybody? Right. Jim Meyer was not the greeter, but we had Janet was the greeter. Thank you, Janet Schwartz, always pitching in. Give her a clap. In lead in the Pledge of Allegiance. Everybody stand up. Join me.
With liberty and justice for all.
Excellent. The thought of the day. Nancy, you want to come up? You're coming.
Slowly.
Take your time. Don't trip on the sword. Here.
Happy birthday, Ben.
Thank you much. It happens to be great. What a great way to celebrate. 72, not 50.
I've been thinking about the fact that this club works hard at having a positive impact in our community. And it gave me the idea to step back and look at the massive impacts that some legendary Rotarians have had in their fields and on society at large. So I'd like to share some quotes from some names that you have heard of many times. Winston Churchill, a member of the Rotary Club of London, said, "We make a living by what we get. We make a life by what we give," which echoes the philosophy of Rotary of selfless giving and service above self. Thomas Edison was a member of the Rotary Club of Orange, New Jersey. He said, "Our greatest weakness lies in giving up. The most certain way to succeed is always to try just one more time, which reflects our commitment to persistence in pursuit of community service and global change." Orville Wright was a member of the Rotary Club of Dayton, Ohio. If we worked on the assumption that what is accepted as true is really true, then there would be little hope for advancement, which embodies the Rotary spirit of innovation, growth, and improvement. John F. Kennedy was a member of the Rotary Club of Hyannis, Massachusetts, and we all recall from his inaugural address, or read in his inaugural address, "Ask not what your country can do for you, ask what you can do for your country," which again emphasizes the central Rotary value of selfless service to the community. And Franklin D. Roosevelt, a member of the Rotary Club of Albany, New York. "The test of our progress is not whether we add more to the abundance of those who have much. It is whether we provide enough to those who have little." And this again reflects the Rotary goal of helping those less fortunate and promoting fairness and equity. A few other names that are kind of astounding: Pope Francis, Walt Disney, Luciano Pavarotti, Neil Armstrong. So we're in great company. Thank you.
Thank you so much. Welcome, Phil. Good to see you. Okay, let's move right along. Oh my God, we're going to sing a patriotic song, led by our song leader, Ed Galt. And everybody, let's stand up right now. Everybody.
I thought today, as our esteemed leader says, patriotic song. Everybody knows it's very beautiful, and wear the hat we recently given the war during the Civil War.
It's okay. I want to see this happen. Oh my God, look at this. He sure was here.
He didn't pick sides.
Okay. Oh, you beautiful for space.
Thanks the sky.
And the waves of
majesty of America, thee and all thy good with brotherhood. Being seen.
Yes. Do you know them?
The original words were the words that God saved from the way down.
Oh, God save the queen. Okay. Okay.
All right, can you all stand one more time, please? And this is, we have to sing happy birthday to fearless leader. And it's his birthday today. Okay, all of mine.
And I have to Wow, what a special birthday. Play ball. Thank you, Jim Crane, to doing the windmill. Gordon, do you want?
No, I just took it up from there, it's just another video.
You know, maybe you never know.
We want to enjoy the real.
Get you up later. Are there any visiting Rotarians here besides my speaker and friendly neighbor, which I'll introduce when appropriate? But our speaker is Neeraj Sood, and get ready, boys and girls. We're going to have fun. I'm trying to think. I know he can make this amusing. When I looked at the slide presentation, I'm going, whoa. Is anybody a scientist? Just raise your hand. Besides the man over there. Scientist. Okay, the one next to you, perfect, jump in. Neighbor. Okay, let's move on. So let's do a recap of what we did with Surfrider. I had Over and Steve Day were with us, and we're at the beach, not far from back at the beach. And this, by the way, is my flagship project. We're going to do cleanups, decide, we're going to join with BCH, is that what it is? What is BCA? What's the other one, Jill? BCC, excuse me, BCC, we'll do some of those. But we're going to do once a month a Rotarian cleanup. We're going to set it up, and we're going to have it, we're going to pick different places, but we're going to go out to other people in the district, so we're going to do that. And just so you see, I didn't do the cleanup by register. I'm not that, I couldn't be under the sand picking up stuff yet. And by the way, this crew is available for cleanups because this is a Pepperdine fraternity. And they have 25 people and they do service once a week. So when I just have to let them know in advance, we can bring you, see, we can blow through a big area.
Did they do enough calls?
What?
Did they do enough calls?
You know what, after you're moving, maybe. Here's another. Okay, this Saturday, Marcia, do you or Diane want to talk briefly about it?
You want to talk about it? You want me to?
You do it.
Well, this Saturday down in San Pedro, oh, can you hear me on Zoom? I don't know about this. This Saturday down in San Pedro, from 10 in the morning to 4 in the afternoon, is the Day of Peace. And as I said last week, it's with the Rotary District 5280 and Roots and Shoots, which is Jane Goodall's charity. And Jane Goodall will be there in person, not on Zoom. She has to send a video. She's going to be standing there amongst us. And she's going to speak at 2:30. And she's been one of my idols for years. At the bottom of my emails, you'll see I quote her. And I different quotes I quote all the time from Jim Goodall. And I have all of her books and everything, so I'm really excited about it. And there'll be food trucks there, there'll be booths, all kinds of things going on. And we're going to have a booth, the Rotary Action for Peace for District 5280 is going to have a booth. And it's really going to be a good day. There's parking, this is a park, and I guess there's street parking, so I think a lot of people are getting there early. But there's like what they call an overflow parking lot, 22nd Street. If you check your email, I sent everybody an email this morning, and it shows you where you can park in a parking lot at 22nd Street, and then there's a bus that goes back and forth all day from that parking lot to the park. So, and carpool, because that's more fun than driving by yourself anyway. But it'll be a really fun day for all, and I hope to see you there. I'll be there. Okay.
So will Diane.
So will Diane.
Diane will be there. Let's move on. Announcements. Let's go over. October 2nd, all sold out. It would be the humanitarian trip to Maui. We have a Rotaract that was sponsored to go there, correct?
Correct.
And then we have a walk for polio at Verdugo Park in Glendale, followed by a barbecue. It doesn't say time, but I'll put that out. I'll put out some information. Again, we have the November 2nd district annual foundational gala called the fourth, SoFi. Mark Rogo sponsored a table. We're going to have a table. So anybody who wants to additionally register, please do it as soon as possible because tickets are very limited. One other announcement that's not on this, please put this on your calendars and I'll remind you. December 5th meeting is not in the day. It is 5:30 at night. We're having the district governor here, so we are honoring his request to be here on the 5th. Those of you who can make it, be fabulous. We're having a joint meeting with Rancho Park Rotary.
English or Farsi?
No, we're doing it in English. Yes.
Here?
Here, at here.
What should
500. And I just want you to put that in your mind and I'll send out a reminder. Tom, you'll be here. Yes, Diane.
Which means the shopping spree this year will be the second Thursday in December instead of the first.
Yes, well, definitely. Okay, this was sent, hold on. This was sent to me this morning by Marcia. And this is an inspiring a minute and a half I want you all to hear. So when you're ready, Tia. I don't have to do anything, go ahead. This is from Kharkiv. This was sent by some people that they recorded living in hellfire. And so here are people that are inspired by being alive. So
I understand, these are all interacts, they're interacts for Rotary. And they're in high school in Kharkiv, it's 50 miles from the Russian border, and that city's been being bombed constantly. And these kids, you have to listen, obviously English is not their first language, but their English is a lot better than my Ukrainian.
yes,
But this is what peace means to them.
okay, let's cue it. could actually have been the thought of the day. I mean, this is, and my feelings about this, when I heard it, I was inspired, wasn't depressed, because these are people that are survivors. They're surviving hell. And we just have to keep them in our prayers, and hopefully this will end at some point in their lives, okay? So, let's go on. Super Bowl poll with Tom Barron. I didn't forget about you, Tom. I'm going to suggest, since we have a packed deal, can we do this at the end of the meeting? Yes or no?
Yes.
Yes.
No, wait a minute, next week.
Next week we can do it. Next week we can do it. Okay?
Whatever you want.
Well, I won't be running it. Diane will be running it next week, but I think we have more to do today than the Super Bowl. So can we defer to next week?
I'll coordinate with Diane.
Okay, please. That'll be terrific. Thank you, Tom. Okay, so this is something that we want to talk about. We had a board meeting the other day, and it turns out we were reviewing the financials. There was a couple of things that were glaring. One, 7 years ago, when these dues were, that was the last time we raised dues. So we decided as a club, our board, that we're going to increase all of the, especially the active, $50 a quarter. Correct, Terry? Okay. Now, what does that represent with all this change? It puts $2,160 additional in the kitty. We're still in the part. Why? Because not everybody shows up for meetings. We'll talk about that another time. We're not going to. So I just wanted to make this announcement. This is not up for discussion. This is just, and it starts October 1, correct? So we're going to make some other changes. All we want to do is break even. We don't want to lose money. Really, isn't that the bottom line, Terry?
Bottom line.
Okay, so when we looked at this, and I'm not even a financial person, but I'm looking at every time for lunch, we're subsidizing typically 5 lunches. Now, I just talked to Ruth, we may have a compromise, 22 instead of 25. So she's working with us. So everybody, thank you for your indulgence. We got a lot to cover. Dr. Neeraj Sood, he's a professor at SC, Price School of Public Policy, director of COVID Initiative. And I gotta tell you, on a personal basis, one of my nicest neighbors that I've ever had. Good man, love his family, they're like our family. And when I asked him to speak about COVID, the back things that we didn't know about, why did they do what they did, all of the things that are going on that made us crazy, businesses closed, masking. And I thought we would share, would have Neeraj talk about this. Neeraj, bring you up.
So thank you, Benjamin, for inviting me here and for the wonderful introduction. I'll talk a little bit about my work on COVID. I'm happy to take questions as I talk or afterwards, or whatever you prefer as an economist. So I'm used to people asking me questions. So don't worry about.
So Neeraj, why don't you make it?
So any questions you have, feel free to ask. So I want to kind of take you back, and I also don't like to stand at the podium. Can I wander?
Yeah. So wait a second. We have a wireless mic set up. Hold on. No, listen. Set it up. So you can talk.
I can start. So I want to take you back to the beginning of the pandemic, when the WHO and many other international organizations were saying that if you get COVID, there is a 3 or 4% chance of dying from it. And if those numbers were right, then COVID would truly be catastrophic, which means within a span of 6 months, millions of people would die. But when I saw this number, I wanted to figure out, as a public health scientists, where are these numbers coming from, or how did they come up with these numbers? And the way they came up with these numbers was, at that point of time, COVID testing was very limited, right? So this is back in March of 2020. So what they were doing was, when people were showing up in the hospital with severe symptoms, they had 2 tests available. They would test the patient. And again, at that point of time, there was really no treatment for COVID. So you were basically testing sick patients to isolate them from other patients in the hospital. And what they found out was that out of these patients, about 3 to 4% of them were dying in the hospital. And as an economist or as a public health researcher, the way I would look at this is, hey, if I want to estimate how many people are truly dying from the disease, I don't need to go to the hospital and test them. What I should be doing is taking a random sample of the population and then testing them and then figuring out how many of them die, right? So this is like, suppose I want to know the average income of people in Los Angeles. And suppose I say, I'm going to go to Beverly Hills or Rodeo Drive and ask people what their income is. And do we think, are we going to get a good estimate of the average income in LA? No. So it was the same. If you're just testing patients in hospitals who are really sick, you're not going to get a good estimate of the true mortality of the disease. So I published an op-ed in the Wall Street Journal that basically said that it's too dangerous to test only the sick. And then basically what I was saying is, based on these numbers, we are shutting down the whole global economy. We're shutting down schools, we're shutting down businesses because we're panicking. We're looking at, if these numbers are truly correct, then millions of people are going to die, and it makes sense to shut down everything. So what I said is, before we do that, let's do the study. Let's try to figure out what the true mortality rate from COVID is. So I published this op-ed. After I published this op-ed, there are a lot of good people in the US. So people just reached out to me from all over the US saying, we love this idea, we want to help you do this study. So I had someone who I'd never met before said that I'm procuring these antibody tests for Major League Baseball and NBA because they're also worried about what's going on and they are losing a lot of money if there are no games going on. But I can ship you some of the tests to your home. So I was like, great, ship me some of these tests. Then I called LA County Public Health and I said, hey, I want to do this study. And they were like, but we don't have the test. This is a great idea. And I was like, don't worry, I got the test. They're on the way here from China. So in a span of 1 month of publishing this, which in research, speed is breakneck speed, we actually did the study. So this is me presenting at a press conference, and this is me at one of the testing sites. And basically what we found was that the number of true infections in the population was 40 times larger than the actual reported cases by LA County Public Health. So LA County Public Health said there were 1,000 people in LA County that had COVID, and our estimates were, no, there were actually 40,000 people who had been infected. But most of the infections were unreported because there was no real testing at that time. And so what this implied was that the true mortality rate of the virus was much lower than what those initial estimates were. So it was actually in the range of 0.2 to 0.3%. So this was the first study to kind of show how many people were infected. So this is kind of what is called a seroprevalence study. So when we did this study, it basically lit up the internet. It was tweeted all over the world. I had a personal PR person because I was doing media interviews every 10 minutes and so on. So, but what happened after the study was published was many other researchers around the world did similar studies. So this graph kind of shows all the other studies that were done in the US and other countries and what they found. And again, the median estimate from these studies, so you can see the mortality rate of the virus varies across countries. It's not the same in every location. But the median estimate is exactly what we found in our study. So again, like this confirmed that, look, it is a more deadly virus than the flu. So the mortality estimate is twice or thrice higher than the flu, but it is not what we originally thought it to be, which was 100 times higher than the flu. Yes.
I thought the fatality rate was mostly with people with underlying conditions.
So you were right. No, so there's two factors that determine the fatality rate. One was age. So the older you were, the fatality risk skyrocketed. Yeah. And the second was underlying chronic conditions, especially obesity. So those were two huge factors determining the mortality rate. So for example, for children, the fatality rate is really, really low. It is, close to zero, like very close to zero. Like for example, in the first year of the pandemic, there was no child who died in LA County from COVID. But we had thousands of deaths among adults. So the fatality rate among older population is like 1,000 times higher than the fatality rate among the younger population. So that's kind of what's shown here. For the 0 to 19-year-olds, like you can't even fathom how small this number is, 0.0003%. But for 60 to 69-year-olds, that's 0.5%. That's a pretty big number, like 0.5% chance of dying. If you did about it, yes.
Why was Delta so strong compared to what we have now? I mean, because that's what I.
Yeah, so I think what happens, so there are two reasons, or the primary reason is because the virus mutates. So the virus mutates and it can mutate along two dimensions. One is it can become more infectious, and the second is it can kind of become more deadly. But over time, and this is just kind of evolution or natural selection, the viruses that are more deadly don't survive because they kill their hosts and then they don't have an opportunity to propagate. So the viruses that are less deadly but really infectious, those are the viruses that survive in the long run, right? And that's why the cold doesn't kill anyone, but it's super infectious and it's surviving for thousands and thousands of years. So that's kind of the evolution of the virus. And the other thing is, initially when COVID happened, our immune systems were not used to this virus. So our immune system was not prepared for this virus. But once you get a COVID infection, then your immune system remembers that it was infected. And so the next time you get an infection, your immune system is already ready to attack and control it. So that's kind of the idea of natural immunity, that the virus becomes less deadly, both because the less deadly versions of the virus are surviving because of natural selection, and we're getting better at fighting it. We're more prepared.
Just so I understand, you're talking about people who had COVID, and what percentage who had COVID died. What percentage of the population had COVID?
I will come to that.
Okay.
So we've done kind of, so when we did this first study, which was in April of 2020, our estimate was around 4% of people in LA County had COVID, which was really high compared to the confirmed cases. It was 40 times higher than the confirmed cases. And then we did a study in, I'll probably switch to that, and I can come back to this. So then we did a study 1 year later, in April 2021, and there our estimate was 72% of the adults either had COVID or were vaccinated. So they had antibodies against COVID. And then the Delta and Omicron surges happened after this time. So we were, in some sense, the first study to show that this concept of herd immunity doesn't hold for COVID. Yes.
How big was the population you sampled, and how did they test? How did you get everybody to test?
Okay. So what we did was, for the first study, we hired a market research firm. The market research firm has a database of around 20 to 30% of LA County's population. Because they're in this business, so they have phone numbers, addresses, email addresses for about 20 to 30% of the population. So from that population, we picked a random sample and we invited them. So the random sample was about 1,000 people, and we invited them. We set up 8 testing centers across LA County, and we invited them to come for antibody testing. And then we used those estimates and some statistics to come up with, the fraction of the population that was infected. So by comparing the characteristics of the people coming in for testing to the general population, and then adjusting those estimates.
And the follow-up studies in Europe and other places, what was their sample size?
So they were similar. The sample sizes varied. There were some studies which had multiple thousands of sample sizes and some studies that had smaller sample sizes. So it just depends. So I'll give you an example. China did a seroprevalence study. They had a sample size in like hundreds of thousands. And everyone participated in the study because in China you don't have an option. Here I have to get informed consent and say, hey, do you want to participate? This is a research study. Here are the risks and the benefits, etc. In China, I reviewed that paper and it was like participation was 100%. And it was.
In all these studies, confirm your original findings?
Yes. So that was this. That was this slide. So all these green bars are showing what the estimates are from those studies. And you can see there is variation across the different studies because they're also testing in different populations, right? But the median estimate is here, which was exactly what our estimate was. So again, there is no one number, right? Like if you say, what's the fatality rate from COVID? I'm going to ask you, tell me the age distribution of your population. If you have a lot of old people in your population, fatality rate is going to be higher. If you have a lot of obese people, it's going to be higher. If you don't, then it's going to be lower. So it really depends upon the underlying characteristic of the population. And there could be some other factors that we don't understand. For example, like genetics. Some people, there's variation across population and genetics, and small variation in genetics could explain susceptibility to disease. So there are kind of a few unknown risk factors related to risk. Any other questions?
So that was when you were walking around the street?
Yeah.
We were going for 15 minutes over. Gotcha.
So then after I did this study, we partnered with, the mayor's office and the LA County Board of Supervisors. So this is me at one of the LAFD stations. And what we were trying to do was come up with new or validate these rapid antigen tests for COVID that we use right now. So we were one of the first to see how good were they. And specifically, I wanted to know how good were they for children. Because remember, schools were shut and we wanted to try to reopen the schools. So there was this one strand of studies which said, look, these tests are not good because they miss a lot of exceptions. So we basically, again, we set up a testing site and we did both the rapid antigen test on children and the conventional PCR test on children, which you have to send the results to a lab and the results come back. The advantage of the rapid antigen test is you can do it at home or you can do it at the point of care. And so what we showed was, yes, the prior studies were right, that the rapid antigen test missed about half of the infections in children. But that wasn't relevant for decision making. Because why am I testing a kid? I'm testing a kid to know whether the kid is infectious or not. I'm not testing the kid really to know whether the kid has COVID or not. Because the kid could have COVID, but it's not really infectious, then I don't care, right? As long as the kid can, attend class, they should be attending class. So what we showed was that if the kid was more likely to be infectious, the rapid antigen test actually caught those infections. So the higher the viral load, the better the sensitivity of the rapid antigen test. So we basically said, look, they're not perfect, but they are good for this purpose of detecting the really infectious kids. And so based on that, we basically collaborated, with a bunch of California schools, the White House. This is what kind of that study was about. And that really led to acceleration of rapid antigen testing in schools and reopening schools using those tests. Okay, this is just, I've covered the, so again, this study also, so, we basically showed that, look, there are a lot of people who have antibodies, and you're still getting these surges in infections. So that shows that this idea of like herd immunity is not going to work for COVID. That this is a virus that is mutating rapidly, and even if you have a past infection or you have past vaccination, you're still susceptible to the disease. And again, these studies also showed that there is a lot of, like the first study showed that there were a lot of asymptomatic infections. And again, that was a novel finding, which was, before those studies, people thought, hey, if you have COVID, you end up in the hospital. We showed there are actually a lot of people who had COVID who don't even know about it. When we did surveys of them and we said, did you have any symptoms? No. But when I test their blood, I see antibodies from COVID. So those antibodies from COVID must mean that they were infected at some point of time, because that's how the body generates those specific antibodies. Yes.
March of 2020.
Yes.
We took a trip to Portland. There was a woman behind us coughing.
Mm-hmm.
My wife said, I'm going to have what she has tomorrow. Next day, she's really sick. We're there, she's with her daughter, she's traveling around buying furniture and stuff around Portland. Gets basically back to LA. She's over, now I'm with her, I'm not sick. Gets back to LA, calls her doctor, said, I think I have what they're talking about. This is the beginning of March.
Yeah.
He said, no. You don't have that. 6 months later, she goes in for a physical. Does a blood test, calls her the next day, says, Sue, I'm so sorry. You did have COVID and you do have the antibiotic. Sent me in the next day to get a blood test. I had the antibiotic.
Well, yeah.
Exactly what you said.
Yeah. And there were a lot of people who did, like your wife felt the symptoms. There were a lot of people who were asymptomatic. And so they didn't even know that they had it. But when you test the blood, you can kind of see the COVID-19 antibodies. So I'll talk about some other research. So now, vaccines came in and everyone was getting the shot. And we wanted to understand, so the traditional view is, look, the value of the shot is that it prevents the disease, right? So if I'm getting the COVID shot, the value of the COVID shot is I don't die from COVID, right? Or I don't get hospitalized because of COVID. But what we said is there's actually a bigger value of the shots is that the peace of mind you get, knowing that I'm protected. And that means you can actually resume your normal activities, you can socialize, you can do other things. So the true value of the shot is much larger than just preventing mortality from COVID. And so again, we use large surveys, nationally representative surveys. So what you see here is anxiety and depression in the US population. So you can see these peaks correspond to the pandemic. And then here I'm showing the fraction of people who are vaccinated. So the moment the vaccines are announced, you can see anxiety and depression starting to go down, right? So it's kind of like the peace of mind. Like I know I'm going to get the shot, things are going to be normal, and then that translated into reductions in anxiety and depression. And what we found was, so you can kind of look at these effects across different strata of the population, and what we find is African Americans, renters, people earning less than $35,000 reported the largest improvements. These were exactly the populations that were hit hardest by COVID, right? The mortality rate was the highest among these populations. So when the shot came in, they had the biggest change in terms of their anxiety and depression symptoms. So again, this shows that, look, there is value of these vaccines way beyond just mortality reduction. Okay.
Is that a target? Is that a target?
Yeah. Okay. So maybe, how much time do I have?
Okay, so you have about You have 10 minutes.
10 minutes.
10, 15 minutes.
Okay. So this is a slide I use in my class when I'm lecturing my class, and I ask my students that suppose you were in charge of COVID policy. You were the White House coordinator for COVID, or you were the president and the pandemic hit. What would you say would be your goal or objective? Like, what would your objective be? And any takers, if you were in charge?
Well, first thing to get vaccinated.
No, okay, that's true. But why? Like, in the sense, what would your big picture, like, what are you trying to achieve?
Educate the population, educate the population.
Educate the population by. So you say you want to reduce COVID mortality? Yeah.
I think the catch, people can be patriotic, and you start saying, be patriotic, be a true American, get vaccinated. That was the message going out.
So my view was, so most of the students say, look, if I was in charge, my objective would be to reduce COVID mortality, either through education or vaccination or COVID morbidity, which is like reducing hospitalization rates, etc. And what I say is, that's not the right answer because it's an incomplete picture. And the reason why it's an incomplete picture is, so you cannot see this picture here, but I can tell you what this picture is. So this picture is from the cover of the British Medical Journal, which is the oldest peer-reviewed journal in the world. And it's showing you all, so at the top you have COVID infection, all the policies being implemented, home isolation, restrictions on essential sectors, transportation restrictions, closure of educational facilities. And then all these boxes are showing all the different things that change as a result of that. And just this box here from the COVID infection is the COVID mortality box. But there are many other things going on in society that also affect mortality. So for example, I did a study where we showed that when you have shelter-in-place policies, or counties that had shelter-in-place policies experienced a bigger decline in mammograms, a bigger decline in cholesterol screenings, a bigger decline in diabetes screenings. And all of those things are now going to affect mortality in the long run. You're going to see more people with late-stage cancer. You're going to see more people with complications from diabetes, right? You're going to see more depression and anxiety if you're not allowed to socialize, etc. So you cannot just be looking at COVID mortality and guide public policy based on that. At a minimum, you need to look at overall mortality. And actually beyond that, you need to look at people's quality of life and their welfare, right? So who here is your objective to live forever? Or, okay, and then if I say you can live forever, if I lock you in that room for the next 50 years, would you want to do that? No, right? So no one has the objective to live forever, right? In our life, we do care about the other things. We do care about socializing. We do care about hanging out with our children. We do care about driving fancy cars. We care about all those things. And so if you're in charge of public policy and you know your citizens care about all those things, you cannot ignore all of those things and say, no, I'm only going to care if you die from COVID. That's not the way to guide policy. So I'm going to skip this part. So this is again a study I did where we're showing what happened in March and April of 2019. And you can see big decrease in colonoscopies, big decrease in mammogram, HTA1 screening, and vaccination rates, right? So then we looked at these same estimates across different counties. Some counties had shelter-in-place policies and other counties did not. And what we find is, what we find is when these things decline, there's an increase in telemedicine visits. What we find is in counties where shelter-in-place policies were there were huge declines, like 23% decline in colonoscopy, 16% decline in mammograms, angiograms, and so on. Okay. Sorry, I'm going back and forth.
Be sorry.
Okay. So now, like feeding off that cover from so there's a lot of research that has tried to look at what impact these shelter-in-place policies have. Most of the research people are familiar with is this chart, which is you want to keep people home because it flattens the curve. So most of the research is if you flatten the curve, people stay at home, that's going to reduce the number of COVID cases, that's going to reduce COVID mortality. But there's a lot of health economic research which says, hey, this is too simplistic a view of what could happen. There are many other things that can happen. One is people can just change their behavior on their own. They don't need government to tell them. If you know there is COVID, people will just sit at home on their own or will take their own measures. The other is it can transfer gadgets from regulated environments such as the workplace to informal environments. What do I mean by this? So suppose I'm allowed to work. I go to USC. USC does COVID testing, has great ventilation, etc. If I'm not allowed to go to USC, what do? I first go hang out with my friends, and then I go visit my grandparents, right? And then that's actually more dangerous than me going to work and staying away and getting tested, right? So there's actually one of my authors did a paper where he found that your risk of COVID is really high 1 week after your birthday. Why would that be the case?
Hold it.
Because you have a birthday party, you get the risk of COVID, right? So,
What was the answer?
what?
Bill's worried, he has a birthday coming. What's the answer?
So the answer is because you have a birthday party. That's the informal gadget, right? You have a birthday, you call all your friends, and then one of them has COVID, and then you get it.
That's right.
So you're out and about on your birthday. You're celebrating, you're going to a movie show, you're doing other things, and that increases your risk. So I talked about the reduced use of healthcare, more stress. There's also research which shows there was more domestic violence because you're, again, stuck at home, right? And that's not a great environment. So what we did was,
Was it more men or more women killing men?
So what we did is, we said, we want to look at not just COVID mortality, but all-cause mortality. Sorry, you had a question?
Oh, I was wondering, I know, I forget what country it is, Sweden or Norway or Switzerland or something, they decided to do nothing, or, not have anybody stay out of school or anything, and they wanted to get herd immunity, that's what they're thinking. How did that, are you aware of?
Yeah, so I'm going to come to that. Actually, this chart shows, so every chart here is a country. And I'm sorry you cannot read the label. And the y-axis is showing excess deaths from the pandemic. So excess deaths are deaths during the pandemic, less whatever was your death rate prior to the pandemic, right? So if there were 100 people dying prior to the pandemic, and there are 200 people dying during the pandemic, the excess deaths are the 200 minus the 100. Right? And on the x-axis I have beats that shelter-in-place policies were implemented during the first 6 months of the pandemic. So if you were a country that shut down right after the pandemic, this would be 26 weeks. If you were a country that took more time to shut down, you would kind of be in this part of the world, right? So this part means you shut down right away. This part means you took time to shut down. And so what is the relationship you see in the data? Countries that shut down right away, if I look at all-cause mortality or COVID mortality, actually have higher mortality rates. So then we said we can do the same experiment in the US. So there were states that shut down early versus states that shut down late. And you see the same pattern in the data, right? And now, so if you are a scientist, you can say, Neeraj, this is correlation, not causation, right? This doesn't mean that the policies kill the people. There could be other things, right? So for example, one story would be states that had, or countries that had older populations, they shut down early and they experienced higher mortality. So it's not the shutdown that's leading to the higher mortality, it's just that countries that shut down had already underlying higher mortality because they had an older population, right? So we said, okay, now we can look at this within a country. So which is, suppose there are two countries, one shut down and the other didn't. So now I can look at the difference in their mortality rate over time and see what's going on. And that's kind of what's shown in these graphs, which is after, so the dotted lines are what the estimates are. So you can see that after you shut down, the mortality rate actually starts to go up compared to other countries that didn't shut down. And prior to the shutdown, actually the trend was the opposite. Mortality rates were going down. You shut down, and mortality rates started to go up. So it took me several years to publish this paper because every time I put these findings, they were like, "Neeraj, this can't be true," and it would get rejected. But eventually, it was published. So this is a contrarian finding, right? Like most of us think that shelter-in-place policies were good. They reduced the number of COVID cases. They reduced mortality. But what I'm trying to say is, look, there's no evidence that even if you don't believe these results, there's no evidence that they save lives. And there are many reasons to believe that they could have led to higher mortality from other diseases because of delayed healthcare, because of social isolation, because of domestic violence, substance abuse, and all the other problems that came essentially with social isolation.
One question.
Yes.
Does everyone have an extra 5 minutes or so? When do you think you can wrap up? Because
I can wrap up right now.
No, or can you stay for a couple minutes?
Yeah.
Okay, does everyone want to stay?
Yeah.
Because this is really interesting. Okay, Diane, do you have a question?
Well, and I don't even know what the question is, but how does long COVID play into this? People that lost their sense of smell and taste still happen.
Yeah. So, in these graphs or any of these figures, I haven't talked about long COVID. I've just talked about, the extreme outcome, which is deaths, right? And right now, the literature is that people truly don't understand what long COVID is. And they feel that what we are calling long COVID could be multiple different things at the same time. So it's not one disease. It could be actually 10 different diseases that we don't fully understand, and we're just calling it long COVID. So for example, I did a study where I tried to understand long COVID. And one of the biggest risk factors for long COVID in my study was having anxiety or depression prior to getting infected. So now you can imagine, so if you have anxiety or depression, and then you get infected, then you start feeling all these symptoms. Now, is that an aggravation of your anxiety and depression? Because one of the symptoms of anxiety and depression is you come up with new symptoms you have, which are unexplained. So for example, like when my father was diagnosed with depression, he would complain about a stomachache. We would get every damn test done, and there was no problem with his stomach. But for him, the pain was real, right? And then we finally went to a psychiatrist, and he says, this is the classical sign of depression. And he took antidepressants, and the stomachache was gone, and everything was fine. So this is one potential explanation. Could be an aggravation of depression or anxiety, or it could be something else is changing in your body. So it could be a respiratory illness that is prolonged. We truly don't know exactly what long COVID is, but we know that a large fraction of people do complain about symptoms persisting 4 weeks past infection, which is kind of the definition of long COVID. So it's a real thing, but we don't know what the root cause is. In some sense, is the root cause COVID, or it's kind of aggravation of already existing diseases, or some combination of those two? We just don't know.
Yeah, did you run any test studies on people who never were vaccinated, whatever became of that? How did they endure this time?
So I have another study where what we did was we used data from different countries, where different countries started their vaccination campaigns at different points in time. So we wanted to understand what is the impact of those vaccination campaigns by exploiting this natural experiment, right? Which is in Benjamin's country, they started vaccinating on January 1. In my country, they started vaccinating in April. So now I can compare the mortality rates across the two countries and see what vaccination was doing. And what we found was vaccinations did indeed save a lot of lives. So in countries that started vaccinating earlier, the mortality rate was much lower than compared to countries that did vaccinate. So vaccination definitely had a mortality benefit. The other thing he showed was if you had, so what happened was the rich countries started vaccinating first, and the poor countries didn't have access to the vaccines and they vaccinated later. So what we show is if we had a more equitable distribution of vaccines, where everyone got vaccines in proportion to their population, then we would have had even a larger impact in terms of reducing mortality. So we were more equitable. So, a lot of countries in Africa, they got vaccines like a year later than when we got there. So if we had been more generous and given some of those countries vaccines, there would have been a much bigger reduction in mortality.
So Tom, you had a question.
Yes, the slide you showed maximize welfare. Okay, didn't you say that was British oriented? That was created by the British?
British Medical Journal.
Okay, is that British? Does that mean if the focus of a country is on maximizing their welfare, that is, reducing the number of problems, et cetera, whereas the United States tried to shut down and reduce the deaths?
Exactly.
So, okay, I'm on the right track?
Yes.
So therefore, we reduce the deaths, but nevertheless, maximizing welfare is the wrong approach versus our approach.
So what I'm saying is, what we did was try to reduce COVID deaths. That's different than reducing all deaths.
Right.
And that's also different than, maximizing welfare. So for example, Tom, what do you care about? Do you care about dying from COVID? Or do you care about just dying? And is the only thing you care about dying? Or do you also care about enjoying your life?
I care about drinking the best wine I can.
Yes. So if I was making decisions for you based on your COVID risk only, I'm like, Tom, I don't care about you drinking wine. I don't care about you dying from heart disease. I don't want you to die from COVID.
Right.
I'm going to make wrong decisions for you, right? I'm not maximizing your welfare because your welfare comes from drinking wine. You're also scared about getting heart disease, and you're also scared about getting COVID. You worry about a lot of different things, and you still want to enjoy your life. So I cannot be just making decisions based on your COVID risk. So that's kind of what my point is, that when I am making as a policymaker decisions for you, I have to worry about the whole of you, not this one sliver of risk, which is your risk of dying from COVID. I can understand that in the first 3 months of the pandemic, because it was new. There was panic. We didn't know what that risk was, and we wanted to understand that. But beyond the point, you gotta say, okay, I've gotta look at all other aspects of welfare.
So basically, Rich, Dave, and then Gordon, and we are done with questions. Okay?
So my question is, do you see a shift in the field for people understanding this? And is there a risk that we overlearn the lessons from this one disease and that the next disease actually behaves differently and we respond in the wrong way because we've learned the wrong lessons from that?
Yeah. So, I don't know how much of the lesson we've learned from this disease, because even among scientists, there are camps, right? So you might think that scientists are objective and neutral and rational and things like that. But in fact, it could be the other way around, which is the smarter you are, the more able you are to hold on to your beliefs. Because, if you challenge me with my PhD, I'll come up with 20 different reasons to argue with you, to hold on to my beliefs, right? So there's one view that, there is even bias in science, and it takes a long time for that bias to go away. When there are like multiple studies, year after year, challenging the dogma. So they say scientific advances are not incremental. They come in like big wave change over several decades. So I don't know how much we've learned from this and whether we behave exactly the same way or in a different way with different reasons.
One last question.
Going back to what you're talking about with Tom. So for Tom, you might maximize some other priorities than you would for somebody else. But doesn't that create a problem? Because if you maximize it for Tom, he could take other people in consideration.
Yeah, I completely agree. So that is a fundamental challenge of public policy. And that's why when people say follow the science for public policy, science can only tell you, it cannot solve this problem. For example, science can tell you what is the impact of closing schools on COVID risk, and what is the impact of closing schools on educational outcomes of children or on their mental health. But science cannot tell you how to trade those off, right? When I had children, my preference would be to, children's educational outcomes would be a big deal for me, right? But someone else, it'd be like, hell with the children, I want to save the lives of adults, right? So how do you decide those trade-offs? Those are everyone's preferences. And those you decide by voting in elections, by getting leaders who will reflect your preferences. But there's no scientific way to address that.
We had somebody in charge of this who said, well, this is science.
Yeah.
We're gonna stop. No comments. Okay, and let's hear. Glad that everyone could stay, because this was really mind-blowing. We've never had this conversation. We've known each other for over 12 years. Come over here. Come. This is a speed. Yeah.
Oh, thank you so much.
Who's got a photo on my table?
Yeah. All right.
Thank you. Just look, Nancy Cohen's giving her craft talk, and Tom Barron is going to do something else. So with that.
Wow.